Hello and welcome to the Laboratory Matters, where we discuss all that matters in a laboratory. This course is entitled Decoding Diabetes Mellitus in the Laboratory. As we are all aware, India is slowly becoming the diabetes capital of the world. And there are lots and lots of youngsters who are turning positive for diabetes, who are testing positive for diabetes mellitus. So it is imperative that the laboratory keeps track of what is new, how to test, what are the various tests that are available, and what is new every day. What is the classification? What are the cutoff values? And how do we say that A or B is diabetic? What is the test of choice to classify diabetes? How do you deal with the complications? How do you monitor the disease? What has the laboratory got to do with diabetes? What is the role that the laboratory plays in diagnosing, detecting, and monitoring diabetes mellitus and its complications? So in this module, we will get an overview of what is diabetes mellitus, how to define diabetes mellitus, what are the various types of the disease, and what are the various hormones that govern glucose metabolism. That's a small introduction to that, along with what are the various samples that you can get in the laboratory to test for glucose or to test for diabetes, and how do we go about collecting these samples. These are the basics, and as always, the basics are the most important, and we always must return to our basics to understand the more complicated stuff. So what is diabetes mellitus, or DM as we call it? Little bit about the history. The word diabetes is Greek for siphon out. Siphon out means drain out, pull out, whatever you can interpret it as. And mellitus is the Latin word which means sweet. So there is a sweet something that is being siphoned out of the body. That's what diabetes mellitus means. And the term diabetes was first used by Apollonius of Memphis around 250 to 300 BC. Ancient Greek, Indian, and Egyptian civilizations have known the sweet nature of diabetes. You can find references to it in all the Indian medical writings, in the ancient medical writings, as also in the Greek and the Egyptian civilizations. So this is a disease that has been known to mankind from time immemorial, literally. In 1889, Mering and Minkowski discovered the role of the pancreas, what the pancreas does in the regulation of glucose metabolism, and what can go, and if something goes wrong, then what happens. But the biggest discovery and a kind of game changer came about in 1922 when Banting, Best and Collip purified the hormone insulin from the pancreas of cows at the University of Toronto. And really, this was one of the best gifts that Banting could give to a diabetic patient, where he offered insulin as replacement to regulate the glucose levels in the body. And that is something that all of us remember, is the discovery of insulin, which could be injected into the human body. Moving on, how do you define diabetes as a disease? So I have used the WHO definition for diabetes, which says that diabetes is a chronic metabolic disease characterized by elevated levels of blood glucose, which leads over time, it's a chronic disease, so over time, to serious damage to the heart, the blood vessels, the eyes, kidney, and nerves. So if you kind of split this definition, one, it's a chronic disease. That means it's a lifestyle disease, lifestyle modification disease. It's a chronic metabolic disease because it affects the glucose metabolism. And what is the mainstay of the disease, or how do you characterize the disease? There's elevated levels of blood glucose. And the presence of increased levels of blood glucose within our body leads to damage of all the major organs like the heart, the blood vessels, the eyes, kidneys, and nerves. So it affects all the organs in the body. And the definition of it is the elevated glucose levels. And when does it occur? It occurs when the pancreas does not produce adequate insulin, or there is adequate production of insulin. The body is unable to utilize this insulin to maintain its glucose metabolism. So it can act in both ways. You can also define it as a group of metabolic disorders of carbohydrate metabolism where glucose is underutilized, leading to hyperglycemia. Hyperglycemia means elevated levels of blood glucose. So whatever the definition is, the way to diagnose the disease is elevated levels of blood glucose. And there is no doubt about that. There is no discussion about that, and there is no second thoughts about it. That is what defines the disease. Now, okay, so you have an elevated level of blood glucose. Are all diabetics the same, or are there differences between the diabetics? So the latest classification of diabetes mellitus is into 4 types. The first type is type 1 diabetes mellitus, in which diabetes mellitus is an autoimmune disorder. So the B cell destruction, or rather the beta cells in the pancreas, get destroyed, leading to insulin deficiency. So this type of type 1 diabetes mellitus is like an autoimmune disorder where the beta cells are self-destroyed, and therefore there is a insulin deficiency. Because there is an insulin deficiency, the glucose cannot be utilized by the patient, which leads to hyperglycemia, and it is called diabetes. Now, this type 1 diabetes also includes LADA. LADA is latent autoimmune disease of adulthood. Usually what we see is type 1 disorder presents quite early in life, and it usually starts when the child is very young, maybe even 1 year, 2 years. So that is what we are aware of. But into this category, because it is the pathology here is autoimmune disorder, they've also included LADA, which is latent autoimmune diabetes of adulthood. Now we come to type 2. This is the most ubiquitous type of diabetes that is there, and this is due to a progressive loss of the beta cell insulin secretion. So you have adequate beta cells, they are secreting insulin, but that slowly decreases over time. So there is glucose, but there is not enough insulin to act on the glucose, which will lead to elevated glucose levels or hypoglycemia, and therefore to diabetes mellitus. So either there can be a decrease in the insulin secretion, or the insulin secretion can be near normal, but there is a peripheral resistance to the action of insulin. So this peripheral resistance to the insulin action will lead to a reduced absorption of glucose, which means that there is elevated levels of glucose in the bloodstream, which causes hyperglycemia and therefore diabetes mellitus. So that is type 2, where you can have a progressive reduction in the level of insulin secretion or a peripheral insulin resistance. Now, type 3 diabetes mellitus is diabetes which occurs due to other causes, not related to the pancreas, not related to autoimmunity. It is monogenic diabetes syndromes, which are neonatal syndromes or MODY. MODY is maturity onset diabetes of the young. Or it could be because of disease of the exocrine pancreas, not the endocrine pancreas in which you have the beta cells which are secreting insulin. So the exocrine pancreas, which could be pancreatitis, cystic fibrosis, or it could be drug or chemical induced. Glucocorticoid treatment, glucocorticoid use for the treatment of HIV/AIDS, post-organ transplant, and what we recently saw is COVID. So excessive use of glucocorticoids can push the glucose levels up, leading to diabetes. We saw this when we were using steroids, rampant use of steroids in the treatment of SARS-CoV-2, leading to uncontrolled diabetes or discovery of new diabetics later after treatment. So this is the third type of diabetes. Type 4 diabetes mellitus is gestational diabetes. This has been included under the classification because we're seeing gestational diabetes also now more frequently. What is gestational diabetes? It is that elevation of blood glucose that is discovered when the woman becomes pregnant and is usually, we come to know of it when the demand increases and therefore you get discovered in the second trimester of pregnancy, and that is type 4 diabetes mellitus or gestational diabetes. So diabetes mellitus can be classified into 4 types from type 1 to type 4, where type 1 is an autoimmune destruction of the beta cells leading to insulin deficiency. Type 2 is the progressive loss of beta cell function and decrease in the insulin secretion or a peripheral insulin resistance. Type 3 diabetes mellitus is caused by other causes, which could be drugs or the diseases of the exocrine pancreas and so on. And type 4 diabetes mellitus is gestational diabetes. Now, briefly, what are the hormones that regulate the glucose levels? So, we just now said that you need adequate levels of insulin, and that is what will regulate the glucose metabolism. So, it decreases the levels of glucose and brings about a normal homeostasis of glucose. So, the insulin decreases the level of glucose. Now, there are hormones which act opposite and they increase the levels of glucose, which will be glucagon, epinephrine, cortisol, growth hormone. All these 4 hormones can give an uptick in the level of glucose, whereas insulin decreases the level of glucose. Now, how do we get this glucose? I mean, there's a lot that's spoken about glucose. Everybody from the doctor to the dietitian to the common man, everybody speaks about glucose. How do we get glucose? So there are 2 methods. One is from the breakdown of carbohydrates, because it is one of the end products of carbohydrate metabolism. So how do we get these carbohydrates? One of it is, of course, the carbohydrate that is part of your diet. The other one is the body stores. Carbohydrate, the excess carbohydrate is stored in the body, and this is in the form of glycogen, and breakdown of glycogen will lead to glucose. So that is one method where from the breakdown of carbohydrates you will be able to get glucose, and this is something like a natural process. Now, endogenously, you can synthesize glucose. You can produce glucose from protein, from glycerol, from triglycerides. So if the body is not getting carbohydrates, then it starts breaking down the protein, breaking down the triglycerides, breaking down the glycerol to derive glucose. Because as you know, glucose is needed for the metabolism of the muscle, for the metabolism of the brain. Glucose is needed by the RBCs. So your body requires glucose. So if carbohydrate cannot supply that glucose, then that glucose needs to be obtained from the breakdown of other endogenous substances like proteins and triglycerides. Whatever it is, this needs to be having checks and balances so that the levels of glucose can be maintained in a normal manner. When we talk of glucose metabolism, we don't have to learn the Embden-Meyerhof pathway, we don't have to learn the Krebs cycle, we don't want to get into those. But there are three words or three terms that one needs to know. One is called glycogenesis. That means there is a production here. So glucose is getting converted to glycogen. So glycogenesis. So there is a genesis of glycogen. It occurs when energy is less than expenditure. So you're expending more than you have. Glycogenolysis occurs when energy is greater than expenditure. So there is glycogen and it is broken down to glucose. Gluconeogenesis, neo means new, occurs when the non-carbohydrate sources are there, when energy is greater than expenditure. So you need more glucose. First you break down glycogen. Glycogen is over. Then you start breaking down the other substances which are non-carbohydrate like amino acids, glycerol, lactate, all that to get the body's supply of glucose. So these three words are some things that you will need to learn or you will need to know when you're trying to understand the process of diabetes mellitus. Now we move on from the basics to glucose testing in the laboratory. It is one of the most common tests. Blood glucose is one of the most common tests in any lab, and most of the health packages will include a measurement of glucose. Now we'll see what are the various samples that you can get in the lab where they ask you for glucose testing. One is serum and plasma, the other is CSF, other body fluids, urine, and you have a whole blood capillary testing for, or as what is a self-test, a do-it-yourself test, do it at home test, or even in the hospital when they want to check when they're administering insulin or when they want to monitor your progress, then you can do a point of care testing or a self-testing where they use whole blood or a whole capillary blood. Other than that, it is blood, body fluids, and urine. These are the various samples that come to your laboratory where they can ask for the glucose levels. Now, how do we collect venous blood? The samples that we collect for the measurement of the analyte called glucose is ideally collected in sodium fluoride tubes today. Now, what is this sodium fluoride? Sodium fluoride tubes are either evacuated or non-evacuated tubes, and they have an ash gray colored cap. So that is how you recognize the sodium fluoride. Sodium fluoride can be present as a powdered form anticoagulant within the tube. Now, why do we use sodium fluoride? Why can't we collect in all the other tubes that we use for chemistry? Now, the sodium fluoride has a property of being an anti-glycolytic agent. So what it does not cause the disintegration of the glucose that is present within the sample. And that's what you ideally need. Any collection into any tube should not help in the reduction of glucose levels. It should be the same thing as it was when I took it from the patient. So that is why we use sodium fluoride, which is a very good anti-glycolytic agent. Now, what does sodium fluoride do? It inhibits enolase. Enolase is one of the enzymes in the Embden-Meyerhof pathway for glucose metabolism. Now, this particular um, chemical reaction requires the presence of magnesium ions. So fluoride ions form a complex with magnesium ions and inorganic phosphate. This prevents the binding of enolase with glucose. So when enolase does not bind with glucose, it cannot be broken down. And that is the way sodium fluoride acts as an anti-glycolytic agent in preventing the breakdown of glucose by acting on enolase. Now, sodium fluoride is also considered to be a weak anticoagulant. So it prevents early clot formation. Now, if you want this to be foolproof, that I don't want my blood to clot, then to sodium fluoride tubes, they've also added the oxalate mixture, potassium oxalate mixture. So potassium oxalate will act as the anticoagulant and sodium fluoride will act as the antiglycolytic agent. So this is the tube, or sodium fluoride tubes are the most common tubes which are used for the collection of samples that require a glucose test on them. Now, talking further about the sodium fluoride tubes. Lot of work has been done on the analysis. Do we really need to use the sodium fluoride tube, or is it okay to use any other tube? Because sodium fluoride tubes are probably adding on to the cost. Now, when you collect a sample in sodium fluoride, it's not that as soon as you collect, yes, that's it, glycolysis is inhibited. No, it's a gradual process and it takes almost up to 4 hours for a complete inhibition of glycolysis. Now, in that time frame, glucose falls by 10 milligram per deciliter per hour at room temperature. So if you have not put the sample inside the fridge, there is a tendency for the glucose levels to fall. Now, how does sodium fluoride act? Sodium fluoride, like we said before, acts on the enzyme called enolase. But enolase occurs very late in the Embden-Meyerhof pathway. Now, by the time this action of sodium fluoride happens on enolase, the glucose has already been converted into several of its intermediate metabolites, which will act in increasing the levels of sugar. So, in that sense of the term, it's not the greatest or the sure shot or the gold standard method for collection of samples for measurement of glucose. Now, research tells you that to the same sodium fluoride, which is an anticoagulant, it's an antiglycolytic agent, you can add citrate buffer and EDTA. Instead of oxalate, you can add EDTA and a citrate buffer. Now, citrate buffer, this completely prevents the glycolysis from occurring. Now, the citrate buffer is at an acid pH, and this acid pH causes the hexokinase very early in the pathway to take the action and prevent glycolysis. So the best combination of tubes, though not commercially available to many of us, is a sodium fluoride citrate buffer EDTA tubes. So this will fulfill all the requirements. Sodium fluoride is being used because it is an antiglycolytic agent. Citrate buffer brings down the pH to acidic value, and it can be used to prevent the action of hexokinase very early on in the Embden-Meyerhof pathway. So if you are able to prevent the action of hexokinase, where it converts glucose to glucose 6-phosphatase, then early on in the cycle, then that is very, very useful. So you don't have to sit and try and find out which is the best tube that I can use to collect my sample in. Now, sample collection in clot activator tubes, red capped tubes, plain tubes, call it what you may, because that is a tube that we are using to collect most of our samples for clinical chemistry. So why can't we use the same tube? So glycolysis decreases glucose concentration by 1 milligram per deciliter per hour in unseparated tubes. So you can collect sample in a clot activator tube, but if you're going to leave it unseparated for a defined length of time like 6 hours or 7 hours, you should remember that the RBCs are in contact with the glucose, and therefore the glucose concentration will reduce by 1 milligram per deciliter per hour. So if you're going to do it after 8 hours, it will probably come down by 8 milligrams per deciliter. Now, supposing this sample is from a patient who has an elevated white cell count, who has a positive blood culture, or any of those kind of added comorbid conditions, there will be presence of leukocytosis, and this leukocytosis again will hasten the uh, decrease or hasten the fall of glucose in the sample. In separated non-hemolyzed serum, two words which are important. One is separated and the second is non-hemolyzed serum. The glucose concentration is stable at 25 degrees centigrade and 72 hours at 4 degrees centigrade. So if you're storing this unhemolyzed but separated sample, the glucose concentration is stable for 8 hours at room temperature and for 72 hours at 4 degrees centigrade. So what they're trying to tell you is you can also collect in clot activator tubes, but you should make sure that there is separation. The serum is not lysed. So it can be serum glucose or it could be plasma glucose. So then if you're using clot activated tubes, then better method to use is a serum separator tube. So blood can definitely be collected in a serum separator tube where gel is there to separate the RBCs from the rest of the serum. So what you need to do as soon as the clot happens, you should centrifuge the sample. Then you get a good separation, and either you can use the same, the same tube, or you can aliquot it and you can use it. So clot activator or a gel tube may be acceptable if the glucose estimation is done almost immediately after sample collection. Now, what is the WHO recommendation? Samples should be centrifuged within half an hour of collection. So there is no point in trying to collect the sample somewhere and transport it 400 kilometers away to get a blood glucose value. You should be able to do it in your lab, but you should wait for the clot to be formed before you centrifuge it. So these are important clues that you get, which based on which you can start collecting the samples for the analysis of glucose. So moving on from blood to body fluids. Every time they aspirate a body fluid, which could be pericardial, pleural, synovial, whatever, it should be one collected in a sterile container and you should send it to the laboratory almost immediately after collection. If the fluid is clear, then the analytes are stable for about 8 hours at room temperature. If the fluid is turbid, that means there's bacterial contamination, it is preferable to process that immediately. If the fluid is blood tinged or cloudy, it should be centrifuged and aliquoted. There should be no contact between the red cells and the fluid. In case of delay, the sample may be centrifuged and stored at 4 degrees centigrade or minus 20 degrees centigrade depending upon the case. So yes, body fluids is an important sample for the estimation of glucose. It should be collected in a sterile container and most importantly sent to the lab almost immediately after collection, because if it is blood tinged, then one would separate it and keep the fluid aside. So all people who are dealing with body fluids need to ensure that if they are not going to process that sample immediately, they're going to centrifuge it and put it into the refrigerator. Next is urine glucose. Urine glucose forms a part of our urine routine examination. All pregnant women who come to hospital get a urine glucose. It is a baseline test in many organizations, in many packages across, in many labs offer urine glucose testing and urine complete testing. Now, if you're not going to process the urine sample immediately and test for glucose, then it should be centrifuged and then it should be stored. If you're going to keep it at room temperature and say, I'm going to look at it later, this will lead to bacterial contamination, and then there is no point because all the glucose will be utilized by the leukocytes and therefore the glucose levels are going to be low. If the urine is bloody, again the red cells which are in contact with the glucose will be utilizing the glucose and therefore that particular level will also be very low. Now, if you anticipate delay, if you're alone, you don't have the time to test it, you say when I'm free I will test it, then you centrifuge it, take off the supernatant, put it into a labeled aliquot and store it at 4 degrees centigrade. So urine glucose, just like blood glucose, just like glucose from any other fluid, should be processed as soon as possible, or otherwise you have to centrifuge it, take out the supernatant and store it in the refrigerator before it is processed further. So we've learned about blood, we've learned body fluids and urine glucose. So the pre-analytics here are very, very important. The tubes are important and whatever processing we need to do is also very important. So to sum up, we've taken our first step where we've tried to understand the disease. We've tried to define the disease where we're saying that it's a group of metabolic disorders of carbohydrate metabolism where glucose is underutilized and this leads to hyperglycemia. Diabetes is classified into four: type 1, type 2, type 3 and type 4. Now, depending upon the expenditure of glucose by our body, it's either stored as fat or glycogen or uh, glucose, amino acids, etc. may get converted to glucose in case of the need for more energy. So if the glucose that you have is not sufficient, you're doing something, more than the amount of glucose that you have in your body, then all these non-carbohydrate and other carbohydrate entities will start getting converted into glucose. So that happens when your expenditure exceeds the intake. And as we said, sodium fluoride tubes are today the preferred method of collection. But if you're going to centrifuge it and process it immediately, you can collect it in a clot activator tube or a serum separator tube. But the ideal tube would be a sodium fluoride citrate buffer EDTA combination of a tube where you're going to get zero glycolysis or zero reduction of the amount of glucose. Body fluids and urine, which are the other samples which we get in the laboratory to look for glucose levels, should be processed immediately after collection, else it should be centrifuged and refrigerated at 4 degrees centigrade. So as we come to the end of this module, we've tried to understand the basic sample that's going to enter the laboratory for testing. Once we've taken care of the pre-analytics, the analytics will follow quite smoothly. So in the next module, we shall learn about the various methods of testing, the various tests that we can do. And until then it's happy learning from the laboratory matters. Thank you.